You're listening to the Assembly on Critical Care podcast, brought to you by the American Thoracic Society.
Welcome, everyone. My name is Divya Shankar. I'm a pulmonary and critical care physician and researcher at Boston University. And on this podcast, I talk to the scientists behind innovative new studies to get their elevator pitch, the big picture story behind their research. And importantly, we explore how their studies can change the way we care for patients in the ICU. Today, I'm super excited to have with me Dr. Kevin Buell, a pulmonary and critical care fellow at the University of Chicago. He's here today to discuss his recent work published in the Journal of the American Medical Association called Individualized Treatment Effects of Oxygen Targets in Mechanically Ventilated Critically Ill Adults. So welcome to the elevator pitch. It's great to have you here. Could you introduce yourself to our listeners, Dr. Buell?
Hi, thank you so much for having me here. I really appreciate the invitation to speak about our paper on behalf of all authors. So I'm Kevin Buell. I'm a pulmonary and critical care fellow at the University of Chicago. I work with several different research labs, including the ICU Data Science Lab, which is led by Matt Cherpek, the Pragmatic Critical Care Research Group, led by Matt Semler, John Casey, and Todd Rice. And this paper also represents a collaboration with ANZIX, which is led by Paul Young. And finally, but not least, I'd like to introduce Alex Spicer, who is the co-first author on the paper. And with all of that being said, thanks again for having me here. I'm excited to talk about our recent publication.
Awesome. And before we get into the paper, what are your interests and what are you working on?
So I'm interested in deriving, testing, and implementing machine learning models to improve the care of critically ill patients with infection and preventing patients with infection from becoming critically ill. And more recently, we've been working on individualized treatment effects in critical care, as shown by the Oxygen paper, and we're hoping to apply those methods more broadly in critical care and seeing what else we can personalize at the bedside.
Great. And speaking of your paper, could you give us the elevator pitch for this recently published study?
Absolutely. So as the audience of this podcast knows, about 13 to 20 million patients are mechanically ventilated every year. But despite this, we don't know what is the oxygenation target that optimizes the clinical outcomes for these patients. We've had many high-quality RCTs over the last 10, 15 years, but globally, they've reported no average treatment effect. There are many possible explanations for this, one of which may be that the effect of lower versus higher oxygenation target have different effects on outcomes for different patients, and that these differences average to zero average treatment effect. And this is a hypothesis that's supported by prior studies suggesting that there is heterogeneity of treatment effect in the field of oxygen targets. The traditional way to look for is subgroup analysis that we're all familiar with, but what we're proposing today is an analysis of individualized treatment effects. This is a new and alternative approach to studying HT, and what it does is that it derives and externally validates a model that predicts the individualized treatment effects of lower versus higher oxygenation target on 28-day mortality for an individual patient. To be clear, we should define individualized treatment effects, so that is the predicted difference in outcomes between two treatments for an individual patient. Now, in real life, we can't observe this because a patient can't be randomly assigned to lower oxygenation or higher oxygenation. So we're really talking about predictions for a model. But thankfully, we can test and evaluate the accuracy of these predictions. So in our study, we derived the model in the pilot trial. Pilot was a cluster randomized, cluster crossover trial published in the New England Journal of Medicine by the PCCRG out of Vanderbilt in Tennessee, USA. And then we took this model and applied it to patients from the ICU ROCKS trial. ICU ROCKS was an individual patient parallel group trial from the ANZIX team in Australia and New Zealand, and our main results are the following. Although there was no statistically significant average treatment effect in ICU ROCKS, the predicted individualized treatment effect of lower versus higher oxygenation targets ranged from a 27% absolute reduction in mortality to a 34% absolute increase in mortality. Patients predicted benefit from a lower SpO2 were older, more likely to be male, and had a higher prevalence of hypoxic and non-hypoxic brain injury. Patients predicted benefit from a higher SpO2 were younger, had higher prevalence of sepsis and respiratory disease, and higher values of baseline heart rate, mean arterial pressure, respiratory rate, and temperature. All that put together, if we had used the SpO2 target in which benefit was predicted for each individual patient instead of the random allocation of SpO2 targets, we would have reduced the absolute overall mortality by 6.4% in the ICU ROCKS validation trial.
That's very cool. Can you talk to us a little bit about the limitations, like you mentioned, of a traditional subgroup analysis and how using machine learning can actually leverage trial data sets to improve the prediction of individualized treatment effects?
Yeah, absolutely. I think that's really the crux of the study. So we're all familiar with subgroup analysis. We see them in every randomized trial that we read. And basically, this analysis will condition the treatment effect on one characteristic. So for example, it would compare the 28-day mortality for patients with coronary artery disease and compare that with the 28-day mortality for patients without coronary artery disease. But we all know that our patients are more than just one variable at a time, and that our patients may have or may not have coronary artery disease, as well as diabetes, as well as age, as well as gender, and many other unique characteristics that make them an individual patient. And this raises two problems with subgroup analysis. First is that, as I said, each patient has multiple characteristics, but subgroup analysis will only study each characteristic one at a time. But second, if you're studying individual characteristics, you can't study the interaction between patient characteristics. And this is really best illustrated with an example. So if you had a model or a patient or a result and it said patients with coronary artery disease benefited from a lower SpO2, and in the same light you had patients benefited from a higher SpO2 with diabetes, well, you wouldn't be sure how to actually care for a patient with CAD and diabetes at the bedside because the treatment effects go in opposite directions when the patient has both variables at the bedside. And what's nice about the analysis that we conducted is that the effect model will incorporate all of patients' baseline characteristics to create a unique prediction. And this prediction is based on the individual values as well as the interaction between each patient characteristic.
That makes a lot of sense. I think one thing that struck me is when you do this in one data set, you have to kind of make sure it applies to other data sets. And you talk about that in your paper. And so what factors do you need to consider when you're choosing your derivation and validation cohort? And why is it important to have both of these groups when using a machine learning algorithm?
So I think that's a great question. And I think it touches on one of the core principles of machine learning and how best to derive and externally validate these models. A big concern about machine learning is that the models can be overfitted to data in which they were derived. And by that, I mean, if you were to train your model at location A using data A, although it appears that the model would function well at setting A, when you apply it for patient B at location B, the model actually doesn't perform well. And this is what you call overfitting. And to prevent overfitting, we will always try and derive in one data set, so where you actually create the model and then externally validate the model in a second data set. There are multiple ways that you can split your data. This could involve a random split, so we've seen like 70-30 or 80-20. You can split by time, so maybe patients before the year 2010 would be in patient A, would be in the derivation cohorts, and patients after the year 2010 would be in the validation cohorts. And lastly, you can also split by site or location, and that was the approach that we did. So the model was derived in the US using data from the pilot's randomized control trial, and once the model was finalized, we then transferred it in time and space and moved it to Australia and New Zealand, and applied it to the data of the patients in the ICU ROCKS trial. And this is important because if the model performs well in the second setting, it gives us increased confidence that our predictions would be generalizable to a different setting.
Awesome. And I think you briefly talked about this, but the machine learning algorithm derivation itself, how does that actually happen? And how do you select the best performing algorithm to test in your study?
So great question. I think there are different approaches to this. I'm just going to highlight our approach. There are multiple algorithms that can be used to predict individualized treatment effect. These are typically publicly available free algorithms for language such as R or Python that you can download onto your software and apply them onto your data. In our study, we evaluated 6 of these machine learning algorithms, and using cross-validation, ultimately picked the one best that we liked. This one best was called ARB. For those who want more details in the weeds, this is a derivation of XGBoost and the R-learner. But for those that don't want to hear this, we'll just say that it's a machine learning model that is used to predict individualized treatment effects. Taking a step back, cross-validation is a technique for evaluating machine learning models by training the model on a subset of the data. So for instance, if you had 5 patients, you would train the model on patient 1, 2, 3, 4, and then you would test the performance on patient 5. You would then repeat this process, but instead you would rotate around which data is in the derivation and the validation cohort. So instead of doing 1, 2, 3, 4, and 5, you could do 2, 3, 4, 5, and 1. And you'd continue this 5 separate times, each time leaving out 1/5 of the data if it's 5-fold cross-validation. And ultimately, this helped us pick the best model of RBoost. And once we'd agreed that RBoost was the model we wanted to use, we derived it in the entire derivation cohort. And once it was finalized and locked in, at that point, you're finally able to access your external validation cohort and you apply it to the new data set to get an honest appraisal of how well your model performs.
And when you did that, did your findings correlate with the patients you expected to benefit from lower and higher oxygenation targets? Or were you surprised by what your machine learning algorithm identified?
So maybe I'll just start off by recapping what our study findings were, just because I know in the elevator pitch, it's a lot of information in one go. So patients predicted benefit from a lower SpO2 were older, more likely to be male, and had higher prevalence of hypoxic and non-hypoxic brain injury. Patients predicted benefit from a higher SpO2 were younger, had higher prevalence of sepsis and respiratory disease, and higher baseline values of heart rate, mean arterial pressure, respiratory rate, and temperature. Some of these are in agreement with secondary analysis of the ICU ROCKS trial. Specifically, in patients with hypoxic ischemic encephalopathy, there were non-statistically significant point estimates that suggested that these patients may benefit from a lower oxygenation target. Similarly, there were also non-statistically significant point estimates that suggested that patients with sepsis may benefit from higher SpO2 targets. On the flip side, our study results are in disagreement with a secondary analysis of the ICU ROCKS trial that suggests that patients with non-hypoxic brain injury may benefit from a higher SpO2. I also think at this point it might be good to just pause and to say a word of caution. That is to say, right now I'm describing the results and describing to you which patients benefited from higher or lower. But in doing so, the model really incorporates all patient characteristics at the same time. So it's not valid for clinicians, based on our study results only, to pick one variable at a time and to say patients with sepsis or patients with hypoxic ischemic encephalopathy or patients with higher age or gender would prefer this type of oxygen target. We'll come to this a little bit later on, but the reality to applying complex models is that you need the entire model to create individual predictions for an individual patient. And based on our study alone, you can't pick one variable at a time and apply them selectively to the patient in front of you at the bedside.
Yeah, that makes a lot of sense and kind of leans into what you were explaining earlier about machine learning algorithms themselves. I guess I'm also curious, how does the heterogeneity of treatment effect that you identified in your study help explain findings from previous randomized trials?
Great question. Also, most of the time, this is like a 10-minute talk to answer that one question. So I'll give you the 10,000-foot overview. And maybe I'll just start off by naming some of the great trials we've had. So we've had ICU ROCKS, O2 ICU, Hot ICU, Pilot, Iconic, and all of these found no significant adverse treatment effects. We've recently had Hot COVID, as well as previously Oxygen ICU, that reported better outcomes from a lower oxygenation target. And we've also had LOCO 2 trial, which reported better outcomes with a higher oxygenation target. So all in all, put all these trials together and the many others that I haven't explicitly named, I think the general consensus up until this point was that there was overall no average treatment effects in oxygen targets. And this can be explained by one of 3 ways, in our opinion. First, the combination of the selected oxygen target, oxygen delivery device, and time to enrollment in each randomized trial may simply not affect the outcomes of the population study. A second option is that each trial was basically underpowered and couldn't pick up the significant difference at the time. And for this reason, Paul Young is investigating mega-ROCs and UK-ROCs of his collaborators to increase the sample size and to detect a much smaller treatment effect. But a third potential explanation is that oxygen targets may have different effects on outcomes for different patients, which balanced out to no significant average treatment effect in a heterogeneous population, or balanced out to a significant average treatment effect in a specific homogeneous population. And this might have been the case in Hot ICU, which was recently published. And this is the definition of AE is non-random variation in the magnitude or direction of the treatment effect. And we believe that our study reinforces this third possibility because we were able to document HTE to the individual patient level and pick out which patients benefited from lower or higher oxygenation target or simply did not benefit from lower or higher.
That makes a lot of sense. And I think leaves us with the big question that I have, and I'm sure many of our listeners have. How do you think these findings and similar studies can impact practice? Machine learning algorithms be used to identify the subgroups of patients who may benefit, and then we take that information directly to our practice, which, as you mentioned, has limitations? Or do you envision a future where we could actually incorporate these models in real time to predict for each individual patient how they would benefit from what treatment?
Ooh, the million-dollar question. What is the future of medicine going to look like, and will there be AI and machine learning inside it? I think the first thing to say is that there are really strict regulations in the US about how and if you can apply these models at the bedside and the amount of further validation that is required. These are all overseen by the FDA. But in my idealistic and hopefully in the near future, I think the next steps would involve further validating the model. The simplest place to start would be to gather other randomized trials who've studied oxygen targets, take the model and apply it to their data and see if we reach similar conclusions. Once that's done, if we have continued confidence in the model, we would have to study it prospectively. And this could very much look like a randomized trial studying usual care in which the physician sets the oxygen target at the bedside versus the physician following the recommendation of the model at the time the patient first starts mechanical ventilation. And in comparing these two arms, if the model recommended SpO2 target outperforms physician care, then obviously we would be encouraged by this finding and have to work towards making the model readily available for the entirety of the world.
Yeah, I think that is the big question. And I think a lot remains to be learned. But thank you for this study that's a step in that direction. And so what is your take-home message and any future directions and future plans on your end?
So I think we could probably conclude with one sentence on what the study offers from a methodological advancement, because I think we'll be seeing these types of studies in critical care more frequently in the future. And then we could conclude on what it means for actual oxygenation targets. So I think for the methods part of it, individualized treatment effects represent a novel approach to delivering bedside, evidence-based, and personalized care. And I chose my words very carefully because they are evidence-based predictions, since they're derived from randomized controlled trial data, and they're personalized because each individual patient gets an individual prediction based on his or her characteristics. For the field of oxygenation targets, the take-home message of the study was that patients experienced lower mortality when randomized to the SpO2 target in which benefit was predicted. And it's for that reason that we believe oxygenation targets that are individualized using machine learning analysis of randomized trials may reduce mortality for critically ill adults. And I really hope that this work continues its impact. I think although the treatment effect may be very small because there are 13 to 20 million patients mechanically ventilated every year, even a minuscule treatment effect could have profound global impact. And for that reason, we really need to urgently validate this model further and look into the next steps.
That sounds great. Well, thank you so much for sharing your insights on the elevator pitch. And on behalf of the ATS Critical Care Assembly, thank you everyone for listening to our podcast. And we hope you'll join us next time for the big picture on the latest critical care studies.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more podcasts from the ATS assemblies on YouTube. Don't forget to like, comment, and subscribe so you never miss a show.